apologise. I know it's Friday afternoon and no one wants to be talking about health and safety. And my presentation, I entitled it Hygiene 101. However, it's more hygiene awareness because I only have 20 minutes and there's no way I can go through all the topics of occupational hygiene today. So today's agenda, I'll be discussing what is occupational hygiene, common hazards in healthcare, some changes to the airborne exposure limits, and also, if I have enough time, maybe noise hazards. So occupational hygiene is the anticipation, recognition, evaluation, control of hazards in the workplace that may result in injury, illness, or disease. And in healthcare, this can expand beyond the workers to include patients and visitors. So basically, an occupational hygienist will look at the work activity that the workers are doing and evaluate, exposure and how to prevent exposure and how to prevent disease, where occupational physicians, they look at treating diseases from the workplace. And sometimes the occupational hygienist may talk to the physician if there's some pre-existing diseases in the workplace. So there's a lot on the slide, but basically we work to a framework, which is we anticipate when new hazards or changes are occurring in the workplace. We recognise existing workplace hazards through doing a walkthrough and assessing what's there. We evaluate those hazards through a risk assessment, through observations, and also taking measurements and comparing that against relevant standards. And we may advise or implement the hierarchy of controls, of course, eliminate, substitute, administrate, or complementary PPE. And then we also have to communicate all this back to the workers and management so everyone's aware of their obligations and the hazards at the workplace. So in healthcare, we have a broad range of hazards, hygiene hazards, and especially based on around geographical location, age of assets, clinical services offered. So the broad main categories are chemical, biological, physical, ergonomical, and psychosocial. And here I've just got some examples of some hygiene hazards and also some general sources in the hospital or healthcare, and I will just zoom in on a couple. So one is asbestos. Asbestos, as most of you will be aware, is a legacy building product in older hospitals. Becomes a risk if we damage or disturb it, or it's friable and it gets inhaled. It causes health risks like asbestosis, lung cancer, and mesothelioma. And we have two main codes of practice. One is how to manage it in the workplace, and the other is how to remove it in the workplace. So most of you will be aware you'd have to have an asbestos register, identify all of the asbestos-containing materials in the building, look at the condition and have a management plan around managing that. And then when workers come to site, also you need to make sure they consult the asbestos register when doing any works on the building. Something else to be aware of, and over the years I've done a lot of work with Australian Border Force where we still see asbestos-containing materials getting imported into Australia. So if you do have new construction works and there's suspect materials on site, best to get them tested. Another common hazard in healthcare is solvents. So we can see these in the BEMS workshop, in pathology labs, and also if we do, some healthcare facilities still do body prep. One important, thing to discuss, which is a bit complicated, so hopefully I can articulate it well, but basically most solvents cause central nervous system depression, and they also have, depending on what solvent they are, they also have lots of other impacts on different organs. But there's this thing called additive effects. So sometimes if you get exposed to one or more solvents, the individual health effects, when you combine them, they're equal, and that's called additive effect. Or sometimes when you expose to one or two or more, solvents, when you combine them, you get this synergistic effect. So they actually more damaging to the body than if they're isolated on their own. So a couple of quick examples, we've got xylene and toluene. They increase liver toxicity. They also are an autotoxic, which means that they cause damage to your hearing, and if that's combined with noise, you've got an increased risk of hearing loss. And also, when you get formalin and you combine that with water, you get formaldehyde, and that can lead to respiratory irritants and also cancer. And if you combine that with other organic solvents, that risk increases. Another common hazard in healthcare is cytotoxic drugs. So these are drugs that are used to treat cancer. I'll just highlight one in particular, carmazine. So it's a very small molecule. It's designed to cross the blood-brain barrier to treat brain cancer. Unfortunately, it has a range of nasty side effects, like most cytotoxic drugs do, neurotoxicity, secondary cancers. And I just want to highlight on the left-hand side of the slide here, this is those purple gloves that you see for handling cytotoxic drugs, nitrile gloves. And we've got, generally most cytotoxic chemicals have a breakthrough time of over 4 hours. Something like carmazine, because it is quite small, it's got 15 minutes before it breaks through those gloves. So when we're handling these things, we need to think about how we have really strict procedures about how they're handled, stored, disposed of, and cleaned up. And we also do environmental monitoring to see that we verify that those handling procedures are effective. Another common thing in healthcare is we build hospitals on top of hills, and they're usually the tallest building in town, so we stick mobile towers on the top of them. The established health effects for radio frequency electromagnetic radiation is tissue heating, and if you're quite close, you can possibly get burns. Your eyes are most sensitive to this, so restricting roof access or restricting access to around where the mobile towers are located, permanent base systems, things like that, to manage that in the workplace. So airborne contaminants, I thought I'd just quickly run through the main ones and remind everyone what they are. So we've got gases, things like carbon dioxide, carbon monoxide. We've got vapors, things that are solid or liquid at room temperature, but if they get heated up or if they have a low boiling point, they emit vapors or off-gas, things like volatile organic compounds or petrol vapors. Dust and particulate matter, things like wood dust, silica dust, fibers, things like asbestos fibers or synthetic mineral fibers. Fumes, that's things that when they vaporize at high temperatures and condensate, you get little particles, so welding fumes. And aerosols, when we're spray painting, we're generating aerosols. If you're using two-pack paints, you could have isocyanates that are respiratory sensitizers, or maybe cooling towers. Also, they generate aerosols with things like Legionella. So when we're talking about particulates especially, size does matter. So most of you are hopefully aware you've got things like inhalable particles, so that's things that you can inhale. The largest fraction of that generally gets deposited in your nose and mouth. And we've also got things called respirable particles. They're much smaller, and they can deposit into your lungs. And if they're really small, they get into your gas exchange regions inside your lungs. Something to highlight with this is inhalable particles. They're generally visible to the naked eye if they're on the larger side, and they tend to settle out of the air very quickly, where respirable particles, especially if they're on the smaller side, they can remain suspended for a very long time in the air, hours after the works are done. So, often, people wear their PPE, they have their local exhaust ventilation systems going, and then they finish the task and they turn it all off, and those particles are still around. So to give an example of this, and I've chosen a complicated one, I do apologise, mold spores. So if you think about Alternaria spores, they're much of a larger spore, and when you inhale that, basically, all it can do is get into your nasal cavity. It may may cause allergenic rhinitis or inflammation of the sinuses. But something like Aspergillus fumigatus, you've got much smaller spore size, and that can get deep inside your lungs. And if you're immunocompromised, that can cause a lot of issues. Unfortunately, things like fungal balls, or in this case, you've got chronic pulmonary aspergillosis, and this poor person, they've got a lot of necrotic tissue on their lung, and they actually lost most of their lung. They've only got one left. Another important concept when we're talking about occupational hygiene is something called systemic and local. So an example of this is respirable crystalline silica. You might have heard of this in the last few years with the the bench tops that are man-made that were banned. But basically, you inhale that particle inside your lung, and it causes an immune reaction, and you get this fibrosis and scarring of your lung. So that's a good example of a local effect. But something like cadmium, it doesn't really matter if you inhale it, if it gets into your nose, or if it gets into your lungs. Your body mistakes it for things like calcium and iron, and so it absorbs it into your body, stays in your body for, unfortunately, half-life of 30 years, so you might have it for the rest of your life. And if the body thinks it's iron, it sends it off to your cardiovascular system, or it could send it off to your bones, and that's my example of systemic effects. It affects lots of different organs in your body. So this is just an example of how we might monitor some of these things. So this is for gravimetric analysis for dust. So on the left, we've got an inhalable sampler. So that does the inhalable fraction. On the right, we've got a cyclone sampler that does the respirable fraction. And if we're monitoring workers, we have to set that up in the worker's breathing zone. In hospitals, we might also do perimeter monitoring. So if you're doing reverberation works or construction works, we might monitor that perimeter to make sure things are contained. Or we might also do static monitoring, where we introduce a new control, and we want to determine if that control is effective. So the reason why I want to talk about this today is we've got workplace exposure standards. They've been around for the last 30 years, and the last time they were updated was 20 years ago. This year, we're having major reforms to the standards. So the workplace exposure standards will be changed to the workplace exposure limits. So that means that we've got another 30 airborne contaminants that we have to be concerned about, and we have over 200 changes to existing exposure limits. Some of those are going up, but the majority, they're getting reduced, and they're going to be more restrictive. Something just to point out with exposure standards is that they are the legal limit that we work to. They're not necessarily a safe limit. So unfortunately, some people will still have adverse health effects even if you keep that, if you're below that exposure limit. So we always try to aim for, as low as reasonably practical. And there's this other thing called non-threshold genotoxic carcinogens. So this is a list of chemicals that will no longer be allowed in the workplace because there's no safe exposure limit considered. So they're actually going to get removed from the WES. But something I just wanted to point out here is something chromium-6 compounds or hexavalent compounds. So they will either need to be eliminated from your workplace, or you need to demonstrate that you're controlling that as far as reasonably practical. So they can get generated sometimes when we weld stainless steel in different processes, and also in situations where we've got stainless steel pipe work that's operating at high temperatures, above 300 degrees. If that's encapsulated with a calcium-containing insulation, there can be a reaction that causes something called calcium chromates, and they're very nasty, so you don't want those in your workplace anyway. I don't envisage this to be a big issue for healthcare. However, maybe medical incinerators, or maybe you might have this around boilers where you're doing the ignition part of your boilers. So something to be aware of. I thought I'd just include this slide. Basically, when we're doing occupational hygiene monitoring, we need to do statistical analysis to prove compliance. So we only measure for 1 or 2 days a year. So we need to do the statistical analysis to show that we comply to the standard. So I won't go too much into this on a Friday afternoon, but I just wanted to point that out. So an example of the WES changing to the WELL, I used welding. So depending on what metals we're welding, what equipment we're using to weld, the different processes we have, we might have some of these chemicals produced or some of these gases. Often we just do a big sweep when we're doing welding assessments, it makes it easier. But you'll see here that things like aluminium, well that's actually a typo, aluminium's changing from 5 to 1. I think nickel is getting reduced by 10%, a few other ones up there, I'll let you find them yourself, but there's going to be a reduction in some of those chemicals. Also manganese and molybdenum, you can see now we have to measure for both the inhalable fraction and the respirable fraction, and we've got the chromium there we're not allowed to have it anymore. So this just means that you might have had previous assessments done, so you might want to go back and review those reports and see what the findings were with these new changes, or you might have to do some more re-evaluation of your workplace. And how much time do I have? I might just...
About 3 minutes, how's that?
Oh, okay, well, I'll go quick. So I just wanted to point out another very common hazard in healthcare is noise. So we see noise in landscape maintenance and plant room maintenance. This lady here, Helen Keller, she lost both her sight and hearing as a toddler, and she said blindness separates people from things, deafness separates people from people. So basically, when you go deaf, it's very isolating. You can't join in conversations anymore. You don't know what people are talking about around you, things like that. So it can cause depression, and it's not very nice. And one other thing too, an important message here is you can always go more deaf. I hear people say, oh, I'm already deaf. If we had any conversation, you still can hear. So you think about that. You can always go a little bit more deaf. So important we protect our hearing. And this is just a quick concept that we're doing a logarithmic scale. So every 3 decibels of noise, we're increasing our noise intensity. It doubles. So, 85 decibels, the exposure limit's 8 hours. And then if we go up another 3 decibels, that halves by 4. I'll keep moving because I'm running out of time. And finally, we've got a number of code of practices for noise in the workplace. But this one here, it's around managing and preventing hearing loss at work. So we've got a hearing conservation program, and basically you should be assessing all your noise tasks in the workplace, looking at hierarchy controls to manage that noise. Things like engineering, where we might, or substitution, we might replace things that are petrol for electric. We might, my mind's escaping me now, but encasing things, deflecting noise, administration controls like maintaining equipment so it doesn't have wheel bearings, squealing, things like that. We should also be doing baseline testing when we hire people, and we should be doing that every 2 years. And yeah, I might leave it there.